and she was rushed to the hospital. She can't open her eyes, she can't speak, and she definitely can't make decisions for herself. The doctor starts listing off a few different options: mechanical ventilation, a feeding tube. All the while, your mind is just starting to race, and the reality of the situation is just starting to settle in. And the stress of making the right decisions just continues to grow. But time is short. What do you do? Today, my presentation is on the utility and role of advanced directives in end-of-life decision-making. We have one overall question of what the utility of these are and what their role is, but we'll answer them with 3 different methods. To roadmap my presentation, I will first be going over the significance of our project and then define what advanced directives are. I'll then give you an overview of my projects and then go through them individually with the aims, methods, findings, and my role in each one. Then I will talk about policy implications and lessons learned. So the significance of our project. In 2010, there was a study that regarded end-of-life decision-making. They found that of 3,700 elderly patients, 43% required decision-making. But of those, only 70% lacked decision-making capacity. So that's kind of a problem. They found that patients who prepare advanced directives receive care that is more in line with their preferences. So these patients had their preferences written down, so when it came to that time where they couldn't make decisions for themselves, then their preferences were carried out. In this study, then 83 to 97% of patients did receive the care that was what they had on their advanced directive. End-of-life care causes post-traumatic stress, depression, anxiety, and internal and external conflict. But there is something that can eliminate or at least alleviate these factors, and that is advanced directives. So what are advanced directives, you may ask? So technically, an advanced directive is made up of 2 parts. The first part is a living will, which is a document that allows a person to declare what their preferences are in the case that they are unable to speak for themselves. The second part is a healthcare power of attorney, which is basically giving someone the power to make decisions for you if you're unable to do so yourself. Studies have found that advanced directives are more common among older and seriously ill patients. An overview of my projects. I will first be talking about a systematic review of the stability of patients' end-of-life preferences. My second project is a qualitative study of the motivations and barriers to completing advanced directives. And the third is a public opinion study of the support that the public have for living will completion programs. So the first project is a systematic review. We wanted to assess the stability of patients' preferences for end-of-life care and also determine which factors affect these preferences change. Our inclusion criteria were articles that had original data on patient stability or changes in end-of-life treatment preferences with time. So what we wanted to look at were studies that had a baseline test and then would test those patients again at 6 months or 12 months. We also had one study that tested these patients over a course of 36 months. What we found were 982 unique articles in Embase and PubMed. We assessed 296 fully for eligibility, found 59 for qualitative synthesis, which means that we use these to determine which factors those are that do influence preferences, and then 23 for quantitative analysis. So we extracted the percentages of stable preferences and also the percentage of patients who had stable preferences. So this is a graph of the percentage of patients with stable preferences over in terms of their level of sickness. So we basically put the tables together to see if there were any patterns, and so we looked at level of illness. We also looked at year of publication and the cohort type. What we found was that most studies didn't have any patterns, and really in these studies individually there weren't that many patterns, and you can see that a lot of them said that stability was stability varied a lot. But if we step back and look at them globally, then there is a pattern in terms of severity of illness. So you can see inpatients, outpatients, and older adults being grouped together here. The outlier here was a study that had a convenient sample of HIV positive patients who were treated in outpatients in a learning center. This is another graph that shows the percentage of preferences stable by duration between assessments. This basically shows that the duration between assessments doesn't affect what stability is. So my role in this project was to do a review of the studies, extract data, synthesize, and analyze, produce tables and figures, and develop the manuscript. Our next steps are to finalize the tables and figures and also complete the manuscript. These are in its final stages, so that's exciting. The second study is a qualitative study where we wanted to look at the motivations for and barriers to AD completion in ill patients. So we wanted to understand who they thought were the best people to go to for advanced care planning and for information about advanced directives. The first step of this was screening patient medical records, again in EPIC, our favorite program now. We looked at patients in the Pennsylvania Hospital, PCAM, and Presby. The eligibility criteria for this were patients who were age 50 or older and had seen these physicians before for cancer and were suffering from end-stage lung, heart, renal, or oncological disease. This is a breakdown of the eligible patients and what their primary diagnoses were. The ones that were the most were lung cancer, kidney disease, and also ALS, which has to do with muscle dysfunction. So our first step for this qualitative study was to do a free listing exercise. We first asked them an example question. So, what comes to your mind when you hear the word apple? So they would answer tree, red, and fruit. And then we asked them what we really wanted to know, which was, what comes to your mind when you hear the word living will or advanced? There is a purpose to this. We wanted to, so hopefully they would answer death and those things. But some of them only said one thing, and some of them had nothing to say. But this basically gives us an idea of whether the patient themselves did not have anything to say in general, or they had more thoughts about an apple over a living will, which could happen. Our next steps for this were to do a semi-structured interview, which basically meant that we had a list of questions, but then we structured it around the patient's answers. So it was catered to the patient individually. And then we had them fill out a demographic survey. So our results for this. After screening 429 patients, 16 consented. But keep in mind that 59% of those consented have not been approached. 59 of the patients we screened have not been approached. So it might seem like a little small, but we did put this study on hold and we're going to be continuing it later. We did find that 6 had an AD and 10 did not have an AD. But why? Why did some patients have advanced directives but others didn't? So we can look at some professional transcriptions. These people had an advanced directive mostly because they thought they were sick. They knew they were sick and that they were getting sicker. They knew they needed to write their preferences down and that they would be close to that stage where they needed to have those preferences written down to get the care that they wanted. So we can see that with the first two quotes. The first one said that he was sick. The second one said that he was sicker, and he wanted to cover his bases. He wanted to make sure that his care was going to be what he wanted. The last two said that from personal experiences, then they knew that advanced directives were valuable. So the second to last one, that patient had an experience with her mother right before this interview, and she said that she had seen how this worked. So she knew what the process of getting an advanced directive was. She wasn't scared about it. She was very happy about getting to know about it a little more and then trying to figure out if she wanted one down the line. The last quote here is about somebody who had the first lung surgery in 2006. So this person had a near-death experience and wanted to know that they would have their preferences written down when it came time. But then there's the other side. Why do people not have advanced directives? So these quotes show that a lot of people have disagreements within their families and are also just not ready. So these first two quotes show that for the first one, then the person's wife didn't agree with their preferences. The wife wanted them to get the most care that they could receive so that he would be there for her when she was getting old. The second quote shows that the son and the husband had different preferences. And this patient said that she would take the opinions of her son before her husband's. Is that a problem? The last two quotes here show that these patients were just not ready. They didn't want to think about getting sicker. They were putting it off and saying, I'm not that sick yet. I'm not about to die, even though I have stage 4 cancer. So my role in this study was to screen the medical records for eligible patients, and then I shadowed interviews. Our next steps is to continue the interviews until we have theoretical saturation, which means that we don't think we can extract any more information from these interviews, and then also synthesize and analyze the data. My third study is a public opinion study. So I want to lay out why we did this. 90% of people in the United States have heard of a living will. 71% have thought of end-of-life preferences, but only 29 actually have a living will. So we wanted to look at what the public thought about different interventions that we could do to increase the completion of advanced directives. Our first aim was to see if they would accept different behavioral economic interventions that are designed to increase AD completion. Our second aim is to see what they think about financial incentives to support these programs. So what we did was we created a survey. It was a 3-page study instrument with the first page outlining some background on our study and the definition of an advanced directive, which was public friendly. And then we had questions that followed a 5-point Likert scale to look at people's willingness to support these programs. And then our second part was filling in a value between 0 and 1,000. So we wanted to see what values people thought were appropriate to pay patients and physicians for these programs. And then the third page was demographics. Yay. So we piloted this at Love Park, and we also went to Rittenhouse. So we hit the afternoon crowds at Love and Clark Park, which gave us quite a high yield. At Love Park, then it was a lot more condensed, and it was easier to ask people around the park and still see our pink papers and know that we needed to pick them up. And so at Love Park, then it seemed as though there was a higher percentage of homeless people, and there were also a lot of Black people. So it seemed that it was representative of Philadelphia. At Clark Park, then it was a lot more spread out. There are 2 parts to Clark Park, bless you. The first, bless you. The first part is tables where people are studying, and there's also chess players who did not want to take our survey. The second part of Clark Park was playgrounds, and a lot of parents were around watching their kids, so it was really easy to ask their parents, the parents' friends, and the friends of the parents to take our survey, which they did, because we gave them a $5 gift card to Starbucks or Wawa. So we hit the weekend crowds at Rittenhouse Square. And here we found that it was a lot more spread out, but it was a lot easier to get people to do it because a ton of people are at Rittenhouse during the weekend. So we just went in a line and basically circled around a lot of times and got about 130 surveys that day. Here are some lovely people taking our surveys with the pink papers that hopefully stand out. So because this is a public opinion study, then we want to see that the people we're surveying are representative of Philadelphia. So what I did here was create a table of participant characteristics of age, sex, race, religion, education, and income. However, you might see a discrepancy. There's some interesting notes here. So it seemed that we got a lot of Black and white people, but a lot of them were also really educated. And then we got the 2 extremes in terms of income. Those who are less than $20,000 and more than $100,000. So we need to compare this to Philadelphia. Granted, Philadelphia and the Department of Health do break down their race in different categories. We can still compare them. So what we see here is that we ended up getting a lot less Blacks than whites, which is kind of a problem. So that's what we tried to address in the other 150 surveys that we later distributed. We also tried to address the issue of income. So because we got the 2 extremes, we wanted to get that middle portion. So when I did all of this analysis, we had about 250 completed surveys. Our target was 400. As of today, we have 350. Good job. So our Likert scale questions were put into pairs, and hopefully these questions, the pairs were basically used so that we could randomize the survey. So these first 2 questions are based on whether health insurance companies should require you to basically have an active choice. You have to tell them if you're going to complete a living will or not complete one. And then the question right next to it is whether your doctor should be paid $100 for talking to you about it and then having you complete it. What we can look at here and conclude is that we should require active choice about AD completion. Or public opinion says that it's okay. And they didn't think that we should pay doctors for completion, which is a pattern that we'll see again later. The next two questions involve whether you should complete a living will without any motivation or assistance, and the question right next to it is whether you should be paid for completing a living will, regardless of what care you would choose. So what we can conclude here is that you should have the free will to complete an AD, but financial incentive is nice but not completely necessary. I say this because if we look at the breakdown of this question, then our highest numbers are from 3 to 5, and then there's low numbers at 1 and 2, which means that people would like the money, but it's not completely necessary. Our next two questions are about whether you should be required to complete a living will for insurance, and then the one right next to it is whether your doctor should be paid for discussing this with you. So again, this is kind of similar to the first two questions. Health insurance application may or may not require completion of an AD, but they don't think doctors should be paid for talking to you about it. So out of curiosity, I ran several regressions. I looked at some predictor variables, which are the fields that we had for demographics, and it seemed that most of these variables actually weren't significant. However, there was one that was significant: race. The way I did this was basically group our whites and non-whites. So I compiled all of the variables that included Asians, Hispanics, and other races into a non-white category, and then I had white as another category. What we see here is that the coefficients are negative. That means that people who were not white were less likely to support these programs where you got paid. Isn't that interesting? Yes. So what we found, from speaking with participants, I came up with a lot of conclusions that I guess we can get from numbers, but you can't really get from numbers. So I found that personal experiences heighten the importance of ADs. A lot of the people who I talked to, after they finished the survey, they said that, oh, like my mom's done this before, and I know it's important. And so they had an idea of how important ADs were. So what we saw from the numbers earlier was that physicians shouldn't be paid for talking about advanced directives because it should be in the scope of their responsibilities. And what we learned from talking to a lot of the participants was that the public opinion study and the survey it needs to be written in elementary language so that everybody understands it. Because if you're too worried, they might just write down a 3 but not really think that. We also saw that a lot of these people started talking to each other and even arguing about how important advanced directives were. Yeah, they're like, do you know my preferences for this? So that was good. My role in this project was to prepare the surveys, pilot the study, and also run some internal consistency checks. I also synthesized the data and analyzed it. Our next steps are to develop some tables and figures, formalize conclusions, and develop the manuscript. Policy implications. So what we saw from the results earlier was that people think it's okay if we have insurance companies require the completion of ADs. And it should fall into the scope of physicians to talk about these things. So we should require physicians to discuss ADs and end-of-life care more frequently and on a standardized basis. Lessons learned. This summer, I conducted a systematic review, read and analyzed more records in ethics, also experienced the extensiveness of IRB modifications, had to approach strangers to collect data, which was weird for me at first, but it was fine. Then I analyzed data in Stata, applied stats to behavioral economics, and also discussed bioethics. Special thanks to my mentors, Joanne, summer staff, and LDI, and the rest of the Fields team. These are my references, and again, I'm happy to take questions.